Man, we have been in this, didn't realize how long this series was going to be. So for all you guys watching out there, I imagine that we had to do this in the 8 hours of the class time. Ooh, oh boy. But I will tell you there's light at the end of the tunnel. This is going to be probably one of the last ones that we're going to talk about for your cardiology part of it, cardiovascular emergencies. We're going to be talking about kind of what causes them, other cardiovascular types of problems that you might encounter. Atherosclerosis, we talked about this. Usually, this is a degenerative disease where the medium or large arteries, okay, and there's a buildup of fat, cholesterol, and the insides of these usually burst, the plaque burst, and eventually causes a hardening of the arteries, okay. When that plaque layer burst, actually it forms a clot, in which case the clot is what now causes a stoppage of the blood flow through that region. All right. Arteriosclerosis, atherosclerosis, they're kind of synonymous. There are differences. The athero means just the vessel itself. Arterio is specific to the arteries themselves. Claudication, remember from our definitions, this is the calf muscles that are not getting good blood supply, and therefore they'll cramp up on you. All right. Aneurysms, again, it's the ballooning of the arteries, usually caused by a weak, in the aorta is where it is. We can have thoracic ones. The picture that I've got on the next slide has got the one that's an abdominal aortic aneurysm. But again, they can be a dissecting, they can be atherosclerotic, they can have an infectious problem which causes them to get bigger. It can be a traumatic problem, okay? They can have a congenital defect which also causes these as well. Now, again, this one here is the abdominal aortic aneurysm, and this is usually caused by years of pressure going through here, and then it slowly balloons out until the balloon can't go anymore. Again, the vessel can only stretch so much, okay? They're usually going to have abdominal pain really bad or back pain, like really bad back pain, okay? Depending on where the tear is where they will feel the pain sensation. Of course, they're leaking fluid out of the aorta. By the way, that fluid leak continues despite, as long as that heart is beating, gang, that's how much blood is going to go out of that thing. Okay. Again, they're going to have the urge to defecate. They're going to want to go to the potty. Of course, obviously, don't let them go to the bathroom. But again, they usually have the pulsating mass in the abdomen. They may or may not have femoral pulses. If it's way down here on these guys, it could actually cause one side to have a pulse and one side not. So on my abdominal pain patients, I always check their femoral pulses simply because I want to make sure that they're not having some sort of aneurysm problem. Okay? If I've got good, strong carotids, but I have really crappy femorals, and then I got a pulsating mass, we have a major, major problem, okay? And it's going to require high flow diesel. This is not one that you sit on scene and get your IV started. This is one that you get to a surgeon post haste, okay? Now, dissecting, it's caused by degenerative change between the smooth muscle and the elastic tissue. So basically, the blood gets in between and it separates the wall, and it can go through the aorta to the associated vessels, okay? And again, the trick is, I can tell you right now, a thoracic aneurysm, once it bursts, your chances of getting those folks back are slim to none. For a dissected aortic aneurysm, again, gently move to the stretcher, get them in the truck, and get them to a surgeon. We're going to call ahead and let them know that I've got I think that I have a busted AAA. And they need to, again, they might actually, and truth be known, taking this guy to a trauma center might not be a bad idea. And the reason that I say that, because, again, a trauma surgeon can actually go in there, open them up in the trauma bay, and actually clamp the aorta for a short period of time in order to get them to surgery, okay? I can tell you the ones that I have had that have survived, we called ahead. Literally, we didn't stop in the ER. We went straight to the surgical suite, and literally they cut them open like they would anesthetize them, intubate them, cut them open, clamp the aorta, okay, and then do their repair, all right? So, and if it's a thoracic aneurysm, even more so, okay? Acute pulmonary embolism. Again, history is going to be your key thing here. Why do they have this, all right? So usually there's a blockage of a pulmonary artery. Now, the good news is you got 4 of them. So can you survive with one of them clogged up? The answer is yes. But again, it's going to hurt like crazy. It's going to cause. So again, the pulmonary artery fails. Again, you can't do it for long, all right? So it really depends on the size and the location of the blockage, all right? Usually the onset is sudden. There's unexplained dyspnea, history of lengthy immobilization, or recent surgery. Recent surgery is kind of a big one, okay? But again, the reason the lengthy immobilization, they develop a deep vein thrombosis that travels to the heart. Speaking of deep vein thrombosis, don't ever massage the deep vein thrombosis. Good chance that you're going to break loose that thrombus. It's going to travel to the heart, get in the pulmonary arteries, and boom, you have an acute pulmonary embolism. Okay? Which is not what you want to do. It needs to be dissolved, or they need to go in and do a thrombolectomy. Okay? Most of the time, I will tell you that they will do go in and they do the heparin integralins. They'll try to bust the clots. Okay. Acute arterial occlusion, usually because of trauma, some sort of tumors pressing against it, or just the actually spasms, or there's some sort of idiopathic, something that the patient has that blocks up an artery, okay? It frequently involves the abdomen or the extremities. Again, the treatment for that is you got to get them to a thoracic surgeon or a cardiovascular surgeon to have them fix that. Vasculitis, okay, inflammation of the blood vessels, usually from some sort of rheumatic disease or a syndrome. Stop and think, vasculitis, sepsis, okay? Now, why is it that doesn't affect them? Usually because the problem with sepsis is it causes everything to dilate out, okay? So it doesn't actually close it up, all right? Again, in vasculitis, usually treated with antibiotic. It may require further treatment, maybe alpha drugs sometimes, not very rarely though, because usually if they swell up, again, usually got to do something to continue to keep the vessels relaxed. It kind of depends on what the vasculitis is doing. By the way, doing an IV improperly can cause vasculitis. That's why you clean it off the site. It's why you prep everything. It's why you don't reinsert your needle. Again, bad ideas, okay? The non-critical peripheral vascular conditions, again, peripheral arterial sclerosis, atherosclerosis. Again, this is usually more defined as a vessel disease that is long-term, poor circulation, if you will. Okay, it can be acute, it can be chronic. The diabetic is usually the guy that gets it, the guy or girl that gets it. And again, you can get pain, coldness, numbness, pallor. Loss of sensation is the other big one. It leads to neuropathy. Okay, so it leads to where you can't feel your foot or you can't feel your legs. Usually, if they have a deep vein thrombosis, you're going to get. Remember that it not only includes the venous return, but then that's going to affect the pulses going down into that area. So there's a blood clot in the vein. It's usually in the larger of the thigh or the calf. You're going to get swelling, redness, tenderness, everything. The one extremity might be nice and puffy. The other one's normal, okay? It's going to be cold to the touch, actually. Gently move them to your stretcher, okay? If that clot breaks off, you're looking at a pulmonary embolus that you can't do nothing about. Last but not least is the varicose veins. They're dilated superficial veins, usually caused by pregnancy and or obesity. They look ugly. They look like spider veins. And really nothing we can do about them. Well, there is something that I've actually know a friend of mine who that's her job. She takes a 29 gauge needle and goes in and puts a drug in there that actually gets rid of the varicose veins. So again, for us, it's a sign that, again, usually it's just a sign of poor vascular condition. So how do we handle, again, the other cardiovascular emergencies? Again, the biggest thing is look for the 5 Ps: pain, pallor, pulselessness, paralysis, paresthesia. Okay? Looking for those 5 Ps when you got an occlusion, a good history, a prior history of vascular problems, and check if you got something in one side, check it on the other side. Okay? A difference in pulses and blood pressures is kind of big when you got a vessel that's stopped up. Okay? Again, transport to the appropriate facility if they're in severe pain, which could happen because of a blockage. Again, consider your use of analgesics, and transport rapidly if you've got a sign of hypoperfusion. That the DVT patient who's got the nice cold leg that's swollen, yeah, they need to get to the hospital like pronto so that the surgeon can actually reestablish some blood flow to the leg. All right. Woohoo! We are done with cardiovascular emergencies. Wow. Now, I'm probably going to throw some more in there, but this is the slide set that's done for this group. And I will see you guys on the next video.